Well, welcome to the last structural session and another case-based scenario that we're going to be talking about. We have a pinch hitter, Dr. Reddy, for Dr. Abdallah Sabbagh, who got canceled. Thank you so much for filling in at the very last minute. We really appreciate it. So please, go ahead.
No, thank you guys. I was just going to enjoy the sessions today, but unfortunately our interventional cardiologist, Abdallah, who I work with pretty closely, and one of the structural imagers, and got canceled like Dr. Sorajja just mentioned, but I'm happy to help present the case. So we're going to be talking about a pseudoaneurysm closure. I have no disclosures. And just a little history of this patient, 62-year-old male, has a history of coronary artery disease and a bicuspid aortic valve. He had his first sternotomy for a CABG about 15 years prior to kind of the recent events, and then he had a pericardiectomy for constriction about 5 years later, and then most recently his surgery was an aortic valve replacement for severe aortic stenosis. So he had a mechanical aortic valve replacement with a 25 millimeter cardiomedics. He had a posterior root enlargement as well, and then an ascending aorta replacement. So I'll show you kind of the clinical challenge here. So he had a pseudoaneurysm after surgery. So he had a lengthy hospitalization after his third redo surgery, ECMO, prolonged recovery, and part of our practice, at least when they get ascending root replacements and mechanical aortic valves, is to get CTs before dismissal. So this was a bit of an incidental finding, but I'll give you a little bit of context in terms of how we managed it. So the June CT is really during the actual index hospitalization after sternotomy, right before discharge. He didn't have any sort of perivalvular leak or any other heart failure type symptoms, so the decision was made to bring him back in about 1 month for a repeat image. And you could see there, just on a comparative similar type of image, that the pseudoaneurysm has now enlarged in size. So I want to pause there and just maybe have our moderators and panelists to talk about interventional strategies.
Yeah, I mean, the pseudoaneurysm looks like it's near in the LVOT region, kind of going towards the right coronary. It looked like just underneath it, the right coronary takeoff. I mean, I've seen this with TAVR too. You can get this type of injury and a pseudoaneurysm there. But I mean, if you're going to plug it, the issue really is, do you have room? And you know, these mechanical leaflets are always a challenge when you're trying to do paravalvular work. There's very little room for forgiveness in terms of leaflet motion and all that. So I think that would be my main concern. And then how are you going to access it? I mean, you can't come through the valve. Mm-hmm. So you're going to have to do some transapical or some, transeptal retrograde, approach.
Agree. I think that I would probably start by seeing if I could hook this with I've done one of these with a AL1 retrograde through the mitral valve. Does kind of look over there pretty nicely. And then my preferred strategy is just to pack them with a couple of coils and put an AD. I like the AD02 for this. It's nice and soft. It's my personal take. If you can't reach it, then I would put a sheath in the LV apex to get there.
Yeah, I agree with all that. Can you go back just to show? Yeah.
And I have some more images too, just to kind of show you the context surrounding structures so that we can better understand it.
You're going to need a multi-device probably approach here. I don't think it'll be one or the other.
Yeah, absolutely.
So where's the entrance? So it's the LVOT.
Mm-hmm. Yeah, absolutely. Yeah, let me kind of go on to the next images just to show. So it is the LVOT. It's right below the valve. And notably, there is no involvement from a valve perspective for perivalvular regurgitation. And yeah, it's right below the valve. It's adjacent to that right coronary artery, but it's not involving the right coronary artery.
Do you have, not involving the right coronary artery, and do you still, during the procedure, have to wire it just to protect it?
Yeah, so, you're talking about how do we access it right now. Yeah, so that was really kind of the procedural planning aspect of it. So when Abdallah and I sit down for procedures like this, we're really looking at that CT to see, well, first off, what's the actual pseudoaneurysm size, but also like what's the actual ostium or the neck of the pseudoaneurysm, because it's not just how big that pseudoaneurysm is, it's what are you going to do to actually access it and close it. So this is kind of the three-dimensional look at it where I could show him the depth, that in the width aspect of it, it's about 6 millimeters. The height is 6 millimeters. Help us better understand like the actual neck of the pseudoaneurysm. And like the moderators had just alluded to, there's a few different access strategies, but part of the discussion really is what do we actually do and how do we actually access it? It is a dynamic structure because with left ventricular contraction, you're going to see that pseudoaneurysm get bigger and smaller. Like I mentioned, we kind of made sure there was no involvement from a fistula perspective, paravalvular leak, any involvement with the coronaries. That would have been multiple different strategies to think about from that standpoint. But no good news for this patient. It was a pseudoaneurysm below the valve without involving any of the surrounding structures that would make it a bit more complicated.
The coils to be named. The Ruby? Yeah, which Jason, what would you use?
Yeah, I mean, you want some type of detachable coil where you can retrieve it if you're not happy with the position. So, I mean, the number makes a great selection of Ruby coils. Turmo does too.
I mean, the challenge with these is that you have to get the whole thing closed.
Yeah.
Because if there's one red blood cell that's still going through, this will stay open. And to me, I would put a bunch of coils in. It doesn't look like you have a whole lot of distance to cover too. So.
And does everybody agree with the ADO2? Is that, how permeable is that?
It's permeable, but
Yeah.
the coils are nice there.
Yeah.
How would you size your ADO2 based on this dimension and your leaflets are open?
Yeah, I mean, so the ADO2, the discs are +6, right? So, and the biggest waist is 6 millimeters. So and this is a 6x6 if I saw that correctly. So I'd probably start with a 6.6 ADO2, or maybe you could do a 6.4 if you didn't think it's very deep. And then you just have to see if that 12 millimeter disc is interfacing with the leaflet over there. And if it's not, you're done. And if it is, then you have to reconsider. But I mean, that's the nature of closure devices, that it's sort of empiric.
Yeah, I mean, I think just even accessing this thing, I mean, this is a patient where I might even just do a diagnostic, cath and just practice, do like a practice run, do your coronaries, your right heart, do a practice transeptal, and see if you can even like get a catheter to engage this thing. I mean, you're going to need some nested catheter system. The backup's going to be really difficult. I mean, the nice thing about the ADO2 is that it's very soft, and so it doesn't require as much backup. If you're going to try to deliver like a AVP2 or something more rigid, I mean, the catheter may just fly out of here. So, and the other thing is maybe just coils, and start with that and see how it goes.
So what type of steerable? What type of transeptal sheath? Gillis, Oscar, medium curve, small curve? What are you guys thinking?
I mean, you made the argument for an AL2, is that what you said? Once you get in the ventricle?
Yeah, typically an AL1 or 2 will reach over. So if you ever have like a caseus mac that erodes and you get a pseudoaneurysm that way, or anything around the mitral annulus where you have to come down through the mitral and then hook back up, the AL platform works nicely. Whether it's a 1 or a 2 or a 3 just depends on kind of where you're going and how much reach you need. But I've found that works reasonably well. It's not perfect,
Sure. Yeah, and I do like the locking feature of the Oscar more so than the Gillis.
I'm a Direx disciple.
Direx,
which is a Boston product. You haven't used it because you hate saving money, but the Direx is like a third the price of an Agilis, and it also has a locking feature.
So it's got a ratchet on it? It has a locking feature?
Yeah,
Okay.
it does. The Oscor, most Oscors they come in a wider range of working lengths,
Yes.
Which is a nice feature of the Oscor, except that you need to then have subsequently longer catheters to fit through them. Whereas the Direx and the Agilis are both like a 72 working length, and you can get an Oscor up to 90, but then it's 105 to the handle. So it's just stuff you have to kind of mix and match.
Totally.
All right, Direx.
D-I-R-E-X.
Okay, we'll write that down.
Yeah. So part of the pre-planning aspect of it is also from my imaging perspective to show him an angle that's reasonable, because on the CT aspect of it, you can make whatever reformat you can look for, but if it's a really kind of steep angle, that's not going to be helpful for you. So that's part of what me and Abdallah talk about all the time, that I get him something realistic to look at so that he's able to see what that valve actually looks like and where's that pseudoaneurysm in relation to it. So you guys talked about different options, including transeptal, but we ended up doing a transapical in this. And from an equipment perspective, all the things that you mentioned, there's a few different options here, including disc-based technology, coils, and the woven endobridge is actually something newer that's been used in the neurointerventional space for saccular aneurysms, for berry aneurysms. I saw a case recently just on social media on being used for a coronary aneurysm, and it was about like 11 millimeter diameter, but that's potentially something to think about. But again, sticking with kind of things that are a bit more traditional. We ended up going for an AVP2 with the transapical approach. And to plan the transapical, again, using that CT to help understand, well, where's that true apex, which rib space is it actually going to be in, whether or not that's actually going to be completely accurate. Again, it's just more about preparation, know what you're expecting, how much subcutaneous tissue are you going to be going through, and more or less it just helps with landmarks. 3D printing is also really helpful in these types of situations, and we've gotten pretty facile with it. Unfortunately, Abdallah had the actual model, but some of the newer 3D printing technology is a bit more, like the ventricle itself is a bit more kind of a rubbery material where you're actually able to plan things a little better. So you can actually simulate putting in a plug there where it simulates myocardium, where it's a little more distendable than like a hard plastic type material. And you're also able to see what's the relationship with the mitral valve opening when you kind of do a 3D printed model like this.
Is this your center does this, Mayo does this, has their own?
Yeah. So our radiology group has
service?
gotten really good with it, and it's gone through various different, forms of it. Like I mentioned, a more hard plastic type material. This is one of our newer type models. But yes, we use our CT, and our 3D lab does a great job in terms of printing this for us. Yeah. So again, the transesophageal echo wasn't done during the procedure. This was just on previous difficult imaging. As you can imagine, LVOT, below the LVOT, there's going to be quite a bit of shadowing, and it wasn't as much used from a peri-procedural perspective. And just a brief kind of segue into when we're talking about a transapical, we have to really make sure that we're going at that true apex where there's not going to be any coronary arteries there. And then using our transthoracic echo, we're able to kind of confirm that landmark to multiple different views, and then setting a landmark with just a fluoroscopic marker. So the first attempt at this was with a micropuncture needle, a long micropuncture needle, but you could see that it wasn't quite reaching, or we're not able to kind of puncture the left ventricle. So they switched strategies and switched it to a 16 gauge angiocath, and you'll see here that they were able to access the left ventricle, and you can confirm that with your LV tracing on that bottom figure there. They were able to access into the left ventricle with their wire. And the first catheter that they used was a JR4, and you'll see that it didn't quite have the reach to get into the pseudoaneurysm space, and it wasn't a selective injection on that second screen too. So they ended up switching over to an LCB 6 French catheter where it had a bit more reach and able to kind of select into the pseudoaneurysm space. The right side of the screen, you're going to be noticing that when they're trying to bring that plug up, that it was kind of bouncing in and out of it, not able to actually deliver the device, and every time they came up with the actual plug, it was kind of bouncing back out of the pseudoaneurysm. So they went a little bit deeper with the catheter, and you'll see that in the first image on the left. They went deeper into the pseudoaneurysm space just to get a little bit more stability, and then able to deliver the AVP2. So the middle picture is the first delivery, and you could see that all the discs are inside the pseudoaneurysm space. So that's another important part of this, is to make sure that there's going to be discs inside, but also a disc outside so that you're actually closing it off. So they ended up retracting it a little bit more and making sure that it actually fits there. And another important aspect of like whenever you're delivering devices right next to that mechanical aortic valve is it actually going to be interfering with mechanical leaflet motion. And again, that's where the 3D printed model helped to make sure that we're going to be not at those posts where it may be a bit of a problem, but in either case, this was a good delivery. And you could see that here when they're confirming it to make sure that there's no residual leak. So the other aspect of this case would be actually closing the transapical. So they ended up using a 4mm AVP2 device to close that transapical puncture, and then used a transthoracic echocardiogram just to make sure that there isn't any sort of hemopericardium, or in this situation, he did have a pericardiectomy, and that's why you're seeing maybe a more unusual kind of staining pattern on that right side of the screen. But in either case, this was a good delivery of this closure device for that transapical access. And then we did a post-procedural CT that shows good exclusion of the pseudoaneurysm space with the device, good leaflet motion, and the patient did well after that. So some of the learning points here: subaortic pseudoaneurysms are challenging, especially in terms of access, and I know you guys talked about transeptal, and we ended up using a transapical approach. There's obviously merits to both things. CT planning is really vital in terms of sizing, route, and making sure that you're not interacting with surrounding structures, and making sure you have good fluoroscopic angles as well, and then making sure that you're at that true apex if you are going to use a transapical puncture. So that's all I had.
Yeah, that's great. I think it's interesting, the defect, when you actually got in, it seemed like the neck was much smaller than you'd measured. But these I guess they're very dynamic, right?
Mm-hmm.
They can really move with the myocardium. So maybe the CT was gated to end whatever diastole or systole, or I don't know what phase it was, but that was probably the worst case scenario.
Yeah, absolutely. So whenever we're going to be sizing it on a CT aspect of it, we're probably going to look to see what's the biggest kind of diameter there. So it likely is going to be towards that end systole, where it's going to be the largest there. Yeah.
Can I make a couple comments about percutaneous apical access that I've just learned the hard way? I didn't see your sheath specifically, or the sheath specifically, but I do want to make a plug for using bright tips in that circumstance. It's just a little bit easier to understand where you are. If you don't have bright tips, there is a knockoff bright tip, I can't remember what it's called, but there are a few options there. A standard pinnacle sheath that you put in, you cannot see in the apex, and so particularly if you have a big person, if it walks itself back or other things, that can be a sort of a way that you can steal defeat from victory. So just a push on using bright tips. And then particularly in the post-pericardectomy patients, I have had a patient die from the plug not being perfectly right, and they get a hemothorax as opposed to a hemopericardium. Hemothorax being a much more occult problem that is harder to treat. And so you can put a O1 through the sheath. You can put a workhorse wire, like a Pro Water, whatever coronary wire you want, alongside your plug, so that if you happen to pull your plug through, which is the way that you can screw that up, you still retain access to the hole, and then you can kind of put a micropuncture system back over that and start again, right? So having a little bit of a backup for yourself, I think, is one of those lessons I've learned the hard way.
Yeah, and so historically we used to do these apical punctures with the Brock needle, which I don't even know if we have those anymore in our hospital, but one key tip there is that they always came with a stylet. So you want to minimize the coring, because if you go with the Brock with a stylet, the LV actually collapses on itself really well, and these direct LV punctures actually, when properly done, it actually can be pretty safe. But I share with you the positioning of the AVP on the way out is really helpful, and I saw how you did that. We did. Chet Rehal taught me this, a couple decades ago. You use contrast to the sidearm of the sheath as you're pulling back, and that contrast will tell you exactly where the endocardium is, and that allows you to put the waist of the AVP right in the middle. And I like the idea of a safety wire being left behind. This is a great case.
So what French slides do you use?
So I'll be honest, I'm one of the structural imagers, so I don't know the exact
French is a sizing mechanism
It's
we
a
use
6
to.
French catheter, but I don't know what sheet that they
That's
used.
all good. So what's the
4mm
largest?
AVP2 on the way out. I saw
Say again?
that. It was a 4mm AVP2.
Yeah, so.
Probably 6 French.
Yeah, I was going to say 6.
No, it's
so
a
what's
6 French
the
catheter,
largest
I just don't know
sheath
the
that
sheath
you've
size.
pulled without closing the hole?
So I have never had the guts to do that, but in my fellowship, we had an old guy who would be like, just pull it. It's muscle. It'll, it closes. And so we'd pull 6 French sheaths out of the LV without closing. And like half the time he was right.
Yeah, and that's so if it's a Brock needle, it's surprising how it closes.
No,
up, believe it or not.
I out of pure ignorance and maybe listening to the wrong people, the first several I did, there were 5 French, and I just pulled it out and walked away and didn't go round later in the day, so everything was fine.
The other key is whatever you do not tie the sheath down or hold it as you're doing these procedures, because the movement of the LV, you need everything to move with the heart. Otherwise, it will cheese slice the apex.
And everybody would close this with an AVP2, or would you use something different?
I think the AVP2 is the easiest to position because the 3 lobes give a little bit of forgiveness, and you can give contrast on the way out to see exactly where you are. But I don't know what has anybody closed it with something else besides AVP?
I've tried ADOs before, but I do like the AVP2 better. I've also seen case reports of people putting microcoils in the set. Have you guys seen this? They put microcoils, you pack the center of the AVP2 with microcoils and then reload it. Because an AVP2 is permeable, it has no membrane on the inside.
Is that the one outside Lab 4, the coils? Or which coils are these?
I've never packed it with them, but I have seen case reports of that. I don't know if it helps.
That's really cool. So you just put the coils inside the middle lobe?
Yeah, and then you pack it in the larger diameter loading cap, like the 7 French loading.
Yeah, Yash.
Before or after you do apical access, do you ever shoot the left coronary again, either at the end or like, hey, should I close like all my do you ever think about that?
I haven't done a whole lot of apical access, but I'll tell you, we historically, I remember Chet asking me to shoot the coronary before and after, and sometimes we'd hit the diagonal branch, but we just never really thought about it. Yeah, because of how distal you are. Yes, Kashish? Yeah, well, I would have chosen either a 4 or 6. It's also important not to oversize, because you can make, remember if it's a 6 French catheter, it's 2 millimeters. You could take this and make it too big and stretch it the wrong way. Kostas, you had your hand up?
Yeah, thank you guys.
All right, great case. Thank you. Who's next? Yash.
Okay, thank you, Dr. Sorajja, for this opportunity. Okay, I'm going to present a...
I didn't come up with that title. Did I?
I think you did. Okay, so this is an 88-year-old male. We did his TAVR in 2023. He had PCI before that. Also has AFib. He's very active. He bikes. And he had a lot of recurrent epistaxis, saw ENT, and just really wanted to get off his blood thinners after his TAVR was done. So he was referred to us for left atrial appendage occlusion therapy. So we had his CT from when we did his TAVR. We used that, just to sort of plan our appendage procedure. We had chosen a watchman. He had adequate depth. It looked like a windsock appendage. The landing zone was pretty good, between 23, 26. And we did confirm that there was no clot. We did the TE. We weren't sure based on the CT. If you see the tip, there's some clot there. But we intra-procedurally confirmed there was no clot before we went ahead with our transeptal. So this is our first picture, a really large appendage, as you can see. And we, based on those dimensions and TE dimensions and this fluoroscopic appearance, we decided for a 31 flex device. So we put the flex in, so we put the flex in, took a few attempts to put it in. We kept getting kicked out by this prominent pectinate that you see in the middle of the screen. Didn't really pick it up on CT as well. So the middle panel at the bottom was the implant, and then I did this Minnesota wiggle because I was trained in Minnesota. And the device would pop out almost 60%. And we did this a couple of times, and I think we were all reluctant to leave this 31 device in. We then swapped for a 27 flex. We sat a little bit deeper, and we were happy with how it looked. There was no leak from what we could tell. In the middle panel, you can see on the fluoroscopic final angiogram, there is some contrast going through, and we thought that was through the cuff, the fabric, the porous fabric of the device. So we released. Unfortunately, at 45 days, he came up with a leak. I don't have those pictures for you, but we went ahead, we did a CT to sort of see what happened. And I'm not entirely sure if we missed this or if the device sort of got malapposed and pushed deeper into the appendage. But at the inferior border, we clearly had a leak, which is a couple of millimeters, but this was basically causing flow into the appendage, and the appendage had not thrombosed. So some of the dimensions we got were sort of on an NFOS projection. It was around 10 millimeters, sort of this crescentic triangular shape, and it was about 19, 20 millimeters deep, as you can see here on CT. Again, even though it was technically only 2 or 3 millimeters as a PDL, but that, contrary to sort of some literature, we thought was significant enough, and clearly the Watchman was not doing its job. So we stopped here. We spoke to the patient and said, options are either we pursue PDL closure for you to get you off the blood thinners, or unfortunately you're going to have to stay on blood thinners. So maybe I'll just stop here and see what the panel would do based on these pictures.
Yeah, a couple comments. So first, the pectinates, that was an issue, and that's shockingly common that the CT looks like you have a lot of depth, and then on the 135 you see these massive pectinates, and it ends up kicking your device out. So you then intentionally decrease the size of your device. What were the compressions, do you know, on the 27 when you put it in?
I think it was between 15 and 20. I don't have those exact numbers. It met IFUs for us to release.
It looked like it was well compressed. So this leak is in a typical position, right? It's kind of inferior posterior. It's almost like an extra lobe there that was missed. You didn't miss it, but there's a whole lobe that's open there, and it's connecting with the PDL. So it looks bigger than 2 millimeters to me. I mean, it's at least 3, I'm sure. But this is something that would be very approachable, with the transcatheter closure, and you're probably going to use an AVP2 again, like the last case. Or you could coil it.
Yeah. So yeah, that's what I wanted to see what you guys would do, which device, coil, plug, how many, and then, based on sort of this crescentic appearance, does it change how you deal with these?
Yeah. Usually, I think the thinking now is if there's a large residual appendage volume, you would like to pack that with coils and eliminate that space, and then close it off with some type of occluder. Could be ADO. If it's a fairly focal leak and there's not a lot of volume of appendage behind that, it may be appropriate just to put in an occluder.
Yeah, that's exactly sort of what my thought process was as well. Sorry, and we got angles just as we do for paravalvular closure from our radiologists. We've been doing most of these with biplane. Just makes things much quicker. Also, based on how this leak was sort of below this Watchman and close to the mitral valve, my goal was to be as anterior as possible. So we did transeptal with a steerable sheath, sort of got in the same fluoroscopic angles that were given to us. And then this was our first picture. So this is just mother and child, so Agilis with a MP. And we actually were able to cannulate this within a minute because we knew exactly where to look. Then we'll go through the TE pictures on the top. So as you can see, the neck is very narrow of this leak. So see how it could be missed, but the body or the sac is pretty big, and there's just constant flow that actually our structural imager was able to see on the bottom right. So quite a large leak now that we know it's there. So we decided that once we've cannulated, then I just use our regular workhorse coronary wire, and these are the Terumo coils. So they come with these pre-made lantern catheters, which are 025. They come in various lengths, the angulation 0, 45, 90, and I think we chose either a 45 or a 90 degree. And then as you can see, we sort of just wired that. Luckily, bounced into the back of the Watchman. We've sized the coils really based on sort of the two diameters of that space, which was pretty big. So we put a 16 by 50 and a 20 by 60 coil, and then it itself sort of prolapsed into this accessory lobe, which we then continued to fill, and we put a fourth coil in there. And actually, on contrast and TE, there was no leak. There was no flow at all. I was also thinking of sort of this hybrid, put an ADO or something in the front, but we didn't need to. And we were quite happy with our results. We sent him home on the same day with aspirin monotherapy. So some key take-home points. CT, I think, is crucial. Data from Minneapolis where planning these with CT helps reduce fluoroscopy time, contrast size. You also know exactly what you're up against. You can decide on your devices. It's very important to have a good transeptal puncture sort of aimed at exactly where that leak is. And then, biplane, certainly if you have it in your lab, would also really save time and radiation for you. Okay. Thank you.
Yeah, that was a very effective technique, great result. I think if you're looking for a more cost-effective solution, because those coils are very expensive.
Yeah.
So that's what $20,000-$30,000 worth of coils there. So
actually, not really. It's $1,500 a coil. I went back and I asked them.
Okay.
So I've been using longer coils just so I don't have to pack as many. So that's 6,000 versus maybe.
How many coils did you use?
I used 4 long ones. Yeah.
So not that much. But I also think because the neck there was very discreet, you could have just used an AVP2, and it probably would have closed fine too.
For sure.
Just a few comments from the imaging perspective. So looking at that initial CT scan, and this often happens when patients are in AFib or slow filling, if you do just that kind of initial arterial phase, you're not really going to see all the pectinate and things like that. Sometimes the delayed phases, it's still difficult to see those pectinates, but at least you can maybe start to plan for that a bit more. Again, it'll rule out thrombus and also that. And if you do have a leak, the more crescentic it is, the more challenging it is to coil. And this one, like we were just talking about, maybe was a bit more of a focal area. You could think about doing a plug. I saw a similar case recently where a plug worked out pretty well. But yeah, I think the more crescentic it is, even if it's just a 2 to 3 millimeter kind of neck aspect of it, the width of like the actual like defect really matters, and you might have to do more plugs like side by side.
We need better plugs. Yeah. What kind of plugs?
There's no reason that plugs should really be mesh metal. Like what? Come on. Everybody knows this, and they're not meant for none of the plugs actually have an indication for paravalvular leak, paradevice leak. They're all congenital indications that we've just happened to exist, and there's an obvious opportunity for things that are more conformable to these semi-crescentic shapes and so forth. So.
Nadir, would that leak have been picked up on ice?
I would say yes. I think that lobe, the posterior lobe, seems pretty big. So I think that, like what to Jason's point, that you downsize it to 27 millimeters, so you go a little bit deeper. So during the intraprocedural imaging, take your time to actually look at the 135 view to make sure that you really covered and go through all the views. And actually 3D as well. I'm sure you will agree with me during intraprocedurally to make sure that it's actually covering the entire left atrial appendage. So just be very gentle, especially when you downsize it, when you know it's usually at 31 millimeter.
But regardless, you got the therapy that needed to be done. So congratulations, Josh. It's a great case.
I think Harsh has a
Harsh next.
So I would say that if you go back to the picture, I mean, I would probably try to deploy it in the posterior lobe with a 31 because the depth was too much. Prevention is better than cure like this. So I would have gone, if you go back to the deployment images, go back to the original deployment. Go back. Keep going back. To the floor of the deployment. One more. Yeah, play that. Yeah, play that. So if you see here, I mean, of course, it's hard to identify the depth of the anterior lobe in an areal caudal, but if you see the posterior lobe is also very deep, so I would probably have gone mid-posterior lobe up, and that 31 probably would have covered the proximal part, especially if you see the proximal part of the anterior lobe being very smooth without any pectinate muscles. I would have probably tried not just putting 31 up, but if that does not work, put it in the posterior lobe and try to see if it covers up.
Yeah, it's a good thought. Usually, though, it just with the posterior deployment, you're gonna end up with a giant shoulder, and that's it always seems like it would make sense,
Yeah.
but the problem is it almost always gives you a huge shoulder.
Well, then you can put your coils in the other lobe. All right, Harsh, I think you're up next. Thanks so much.
Thank you, Paul, for giving us an opportunity from Oregon Health and Science University. So the title of my talk was All Roads Lead to Rome, and I was like a little bit confused about which roads are we talking about. And more importantly, I think the cases which are shown are so complex. I'm a simple person. I want to keep things simple. So let's play the next slide. Is this the green button? I guess so. All right, so the faculty disclosures can be seen. I'm going to go walk here. So I'm going to show two cases just to show the versatility of how we do things in this day and age with aortic valve management. So case one is a 73-year-old female who presented to us with shortness of breath on exertion. Of course, evaluation was severe aortic stenosis with a mean gradient of 48, valve area of 0.7. And off note, she has severe thoracolumbar kyphoscoliosis. She basically sits at 30 degrees 24/7. And her team approach discussion leaned towards TAVR given her body habitus, poor rehab potential, and patient preference. This is her anatomy, pretty straightforward anatomy for a 26 core valve or a 29 evolute, trileaflet valve, big sinuses, and decent coronary heights. This is her, essentially her aorta. So it goes, makes a reverse 8, and comes all the way. And this is the 3D of her aorta. And remember, this is in the background of her sitting up 30 degrees all the time, so she cannot lay flat on the table. So what is the valve choice in this patient? 26 Sapien, 29 Evolute, Navitor, alternate access. She also has, it was difficult to intubate her theoretically because of her position, and getting into carotid access was not going to be the most fun as well. So what would you guys do in this situation at your centers?
Mark.
Oh, come on. Well, I would certainly like to see the axillaries before I committed to a transfemoral.
I see.
because that could be it could potentially be very straightforward.
Let's assume the axillaries
Yeah,
and carotids are
I know
no
you were
go.
going to say that.
How would you do this TF?
Yeah. I'm trying to think what device I would use and whether the ability to flex my device might help some. The relative lack of calcium is nice. So I would probably, I might want to do we don't typically do angiograms on our patients, but I might look for a reason to do an angiogram on her and get a feel for what this is like from the groin. And then I know your next question, which groin would I use? Well, not sure. I think I'd play around a little bit with the diagnostic angiogram first, see how things appear, maybe even use a stiff wire, and just see how things look that way. And then ultimately, I guess I would use either an S3 or a Navitor for this.
So I would consider, I've done this a couple times before, a transeptal, wire out the aorta, snare, create a rail, and use that rail to pull sapien around.
Yep.
And I've done that
Or
before.
that.
and-
Or do that.
Or the valve of your choice.
Yep.
And it's actually worked quite well. And so, yeah, you have to be very careful with the mitral as you're coming out, but having a rail to deliver a retrograde TAVR, it actually works. It works pretty well as long as you're careful with the mitral.
I'll make two. I usually use the Confida or Confida wire, however you say it. But a Safari is 15 centimeters longer, and you can get into length issue. I mean, it's probably a smaller woman, but you can get into length issues with this much tortuosity. So it is a scenario where I think a Safari actually makes a difference to have a little bit longer wire. And given the lack of calcium in this tortuosity, having a buddy wire in the aorta, like a Lundy, from the other side to help straighten things out can sometimes be helpful.
Perfect. So let's hold the thoughts, okay? Let's just remember this case, and I'll go back to the case 1 again. So case 2, 78-year-old female. This was just last week. And I did her case on Wednesday before I came on Thursday. So 78-year-old female presented with shortness of breath on exertion, prior history of bioprosthetic MVR 29 magna and AVR 21 magna in 2018. She's extremely short of breath. She got sent from the clinic, severe bioprosthetic AS with a gradient of 70 across the 21 magna, and severe bioprosthetic MS with a gradient of 18 with severe tricuspid regurgitation. Right heart cath was done the next day, and RA pressure was 16, PA was 45 by 23, cardiac output was 2.4, index of 1.2. This is her anatomy. As you can see, big sinus, big STJ. Coronaries are like, as you can see, the left coronary is right at the level of the valve. Right coronary is almost right at the level of the valve. And but big sinuses, big STJ, and a small valve. And this is her angiogram. Because the root aortogram was done because the referring could not engage the left main. The referring could engage the right coronary artery with this. And wait for it. There's a big strut of mitral valve in the LVOT. So the clinical challenge is patient is too frail for even high-risk surgery per the surgeons. Heart team to approach with transcatheter options. She has severe MS, severe AS, and she's not a surgical candidate. What is the valve choice here? 23 Evolute FX or 20 Sapien 3 Ultra. What is the risk of coronary obstruction here, either with just valve-in-valve plus or minus valve fracture, with the coronaries being so low? What is the risk of valve embolization with balloon expandable platform with mitral valve strut in the LVOT? Will the strut bend? And then do we perform mitral valve at the same time? And what happens to the left ventricle once it's unloaded after TAVR with severe MS still in place? How do you guys approach? Awesome. We'll go back. We'll go forward. So first case, after careful discussion, we decided to proceed with 26 Sapien, as Jamie mentioned, from the transfemoral approach. And this is how it looked in the first few images. You can see she's propped up still. You can see her head in the fluoroscopy images. And this is the buddy lung duct twist through the left groin. to get the pigtail down to the bottom of the cusp. And this is the coplanar angiogram or aortogram, and then this is as the sheath went in. And it is surprising the versatility of the delivery system, that we were able to track the sheath. It was just like driving a big truck in the aorta, slowly and gradually. And we were almost out of the length of safari, as Jamie mentioned as well, but we did have the safari, and we were able to drive slowly and gradually this truck across that tortuous aorta and push the delivery system. And then finally get the valve, and it was pretty simple after that, regular transfemoral TAVR, and then she went home the next day, just like nothing happened. So mean gradient of 8 post-TAVR with trace paravalvular leak, discharge home next day with uneventful course. The second case, after multiple discussions of all the concerns I had, we discussed to go with 23 Evolute Affix with mitral valve and valve as a backup. With 29 Sapien, the LVOT was around 280. So here I am trying to get to CVI in a flight, and this is at 5:30 in the evening on Wednesday, and I'm like not able to deliver this valve because the sinus is huge, and the STJ is huge, and the valve is small, and you can see the patient already has a swan and everything. So basically, this has been well described, but it was pretty simple to do. But I think this is an important tip and technique which everyone needs to learn who do these cases. We used a 6 French guide from the left side and 25 millimeter gooseneck snare, snared the wire, and we're able to pretty easily get the snare all the way to the, not into the capsule, but almost at the tip, and then pull, as you can see here. And then we are able, yeah, we had to recross. It was fortunately not that difficult to recross the valve despite being very stenotic. And then the valve was deployed. There's no issues with valve deployment. The question came whether to fracture the valve or not. The gradient was 9. So we decided not to shake the trees much because her mean gradient across the mitral valve was still 20. And she did fine. Her PA pressures came down just with the aortic valve replacement. So the plan is to bring her back in a couple of weeks and do the mitral valve and valve now. She just got discharged today or yesterday. So she was stable post-TAVR, mean gradient of 16 across the mitral valve, and stable post-TAVRs with pressures coming down. So key learnings: newer generation valve platforms have become very versatile in treating various complex anatomies. Understanding the strengths of every system, tracking deliverability, residual gradients is essential to allow for best options for our patients. And understanding various tools and techniques to achieve a successful procedure delivers excellent patient outcomes. Thank you very much.
Not really.
I would love a better. That was a very nice example of the snare pull to the inner curve of the aorta technique. I still hate it because you have to sort of start over, and it's annoying. And I wish there was I'm open to suggestions on better things. Not that it doesn't work or that it wasn't the right move, but like, let's figure something out that's better. And maybe it's just delivery system issues. I've often wondered if I could put a pigtail in the non-coronary cusp and then establish wire access there, and then bring like a 15 balloon down or a 20 balloon and just balloon it over.
Yeah, I've done that.
You have.
Yeah, just push it off that one, piece of metal that's interfering with it, just to buddy it. I think it's not as predictable where that balloon's going to end up and whether it's going to push in the right direction, but it's worked for me. And of course, you can partially inflate, if you're doing the Sapien, you can partially inflate that balloon, and sometimes that'll let you retract into the, I've done that several times. It's not as scary as it seems initially, so. But the buddy balloon thing can work, but the snare thing does stink because you got to start all over. Talking about transapical, this is a redo, a 4 French through the apex if you really wanted to just not start all over. Say you didn't want to take your device off for whatever reason. you could theoretically snare it from the apex of the forefront sheath and just pull it out. But
Kashish, did it affect commissural alignment at all? Because sometimes just changing the splines and the way that they come in can also make it easier to get to the inner curve. But did you find it makes a difference at all?
We didn't look at that, but all of that commissural alignment in core valve is based on post
Yeah.
imaging anyway. So I think at this point you're just trying to get the valve in. But we have not.
Yes, Costas. One.
That idea did come up, but we were worried about that. Severe MS and severe AS, and you have a decent amount of AI and you lose the patient. I mean, we didn't want to intubate this patient as well because of all the issues, so we wanted to be done with conscious sedation as well. So I think that's why we said the snare would be the fastest and the best way to predictably get the valve in.
Great case, Harsh. Let's bring up our next speaker, Wally Omar from Northwell Health is going to talk to us about how and what to close this defect.
Okay, thank you, everybody. I am going to switch gears pretty significantly, something we rarely ever talk about. PFO closure is a lot less sexy, but this is a 47-year-old man. He has a history of Klinefelter syndrome, sick sinus, had a dual-chamber pacemaker placed, and then he had a motor vehicle accident resulting in paraplegia, and recently had a large vessel left MCA stroke requiring thrombectomy by our neuro colleagues. He continues to have some expressive aphasia, and then he had a workup for stroke. He didn't have any hematologic disorders that were found. He had a 30-day telemetry without arrhythmia, and he was found to have this PFO by TTE and TEE. You can see here pretty large PFO with shunting here with a aneurysmal septum on the TEE. He had normal LV function, bidirectional shunting, and then you can see there the bubbles crossing. So I think it was a pretty easy decision to close the PFO based on the fact that he had a recent stroke without a etiology. And so we thought it would be fairly straightforward. Used an Amplatzer talisman device, figured the size would be double that size, so 1.5 centimeters. We'd probably go for a 30 millimeter PFO occluder here. So plan for ice-guided PFO closure, bilateral femoral venous access was obtained, and then was able to get a wire up to the IVC kind of hepatic vein junction, could not get into the right atrium, and then finally was able to get into the right atrium with a wire, but I couldn't get a catheter across. So it took a venogram here from the IVC and noticed that there was an occlusion there. So this is what I was able to get through. This was a glide wire with a glide cath. The glide cath could actually not pass through that junction there and could not get further into the right atrium. And hopefully, I think I'm transeptal there, but I'm not exactly sure. So this is where I am stuck here. So what would you guys do here? Well, we'll stop here. So I got a CT venogram, and then what I found was that he actually had a very diminutive IVC. It tapered down to about 4 millimeters without actual stenosis, but it does take this bend here that goes posterior, and you can see there from the septum, you'd have to make kind of two turns. So one going posterior and then a 90-degree turn going back interior.
So you think about switching to IJ?
Yeah.
Who would switch to IJ here?
Yeah, this is going to be tough, I think, going from the femoral. So I have not, I haven't closed AST or PFO from the IJ, but I think it's obviously doable. So that's probably what I would do.
Do it from the left subclavian. ergonomics relative to the II to be a little easier. You put the table out off the left shoulder. Have done that a few times.
Have you done that with pacer wires, left subclavian?
No, probably not. No.
Yeah. So that was our only concern, was the pacer wires, but agreed that, so we went IJ, we ended up going right IJ, general anesthesia with TE guidance, and then started with a EBU for that curve that you guys saw earlier, so that we can actually get anterior and kind of
one other
superior.
comment, it just makes you wonder though also, like, what is the chance that he actually had paradoxical embolism? I mean, if the IVC is like not even there and it's pointed not at the PFO, I mean, it seems unlikely that that's probably why he had a giant LF-MCA stroke. But anyways,
that's a real buzzkill, man.
Yeah,
we don't need that.
You know, we always try, and we always do stuff, but like, you know, sometimes we think about why are we doing it, but you got to do it. I mean, you know, the guy has a PFO. He's been
But usually these are percentage, like they're 4 millimeters wide, but they're 12 or 15 millimeters the other axis, right? Because you didn't show anything about IVC V waves and stuff, but you know, if they're really stenotic, where you wouldn't get thrombus to them, people tend to have engorgement on the lower extremities, etc. So presuming that there wasn't clinical symptomatology, it is probably a half moon or a quarter moon kind of looking IVC, where it just makes catheter manipulation challenging. And sometimes they'll even open up with stiffer wires. Like if you get across it, put a stiffer wire, it's such malleable stuff that they'll just kind of open. But I don't know if you thought it was really stenotic or if it was just kind of a weird shape.
Yeah, no, I think I didn't think it was actually stenotic. Once again, I was able to get the glide cath across, but couldn't get a stiff catheter or a stiff wire just because everything would just prolapse out. But agreed, it was more catheter manipulation that was difficult. I will say that we definitely talked to the patient and said, listen, PFO closure, we're not going to get a huge benefit from this. But I think it was in his head and in his wife's head more so that that we need to close this because the stroke was pretty scary to them. So used an EBU guide, actually got our glide wire across pretty easily. And you can see on the top right there that we kept prolapsing into the LV. So eventually we were able to get up into the upper pulmonary vein there and then used a 30 millimeter device here. You can see that we're interacting with the mitral valve apparatus, which was quite scary, and just made sure that we didn't go through into the mitral valve or across the mitral valve here. So this is the 30 here. And we realized that we had incomplete coverage. You can see there that there was still a bit of a leak here. So unfortunately had to back out everything, but it was fine. Actually, we were able to recapture and maintain our access into the left atrium without a second wire, although now I realize a second wire would have actually been a good idea just in case after all that manipulation, and upsized to a 34 millimeter PFO occluder here, which looked a lot better. There's some overriding of the aorta, but he did well. Continued on aspirin Plavix for 3 months, remains on antibiotic prophylaxis, and this is what it looked like on his follow-up TTE. So no residual leak, and it looked pretty stable. Transjugular PFO closure is safe and feasible. Care should be taken to minimize interaction with the closure device and the mitral valve apparatus, especially if the delivery catheter doesn't direct the device superiorly, right? So once we got our toric view in, it would always prolapse and point downward toward the mitral valve, which is our biggest issue. And then maintaining TE guidance throughout the entire procedure is important to make sure that we're not interacting with all those other structures. Thank you.
So Wally, I was going to ask you, so we've done this, when we've done IJ, we've used a steerable because a steerable allows you to go 180 in the opposite direction, and you need a larger steerable because obviously these are typically 9 French sheets and Agilis is obviously 8.5. So a Destino or something larger than that. Did you think about a steerable to help get a little bit more coaxial with your device?
Yeah, actually, so once we were, I did not think of it beforehand. Our main issue was, are we going to be able to get everything through with all those pacer wires, number one, that he had there. But kind of when we were in the middle of the procedure, thought about a steerable, and then at that point we were committed. So in the future, I think a steerable would be the way to go if this ever arises again.
Sure.
Yeah.
Sure.
Did you have any trouble with wire prolapse?
Yes. So the glide wire itself would prolapse. So we got across and then got into the left upper pulmonary vein and then passed our catheter forward and the wire prolapsed. And then we got into the right pulmonary vein and then the wire did not prolapse. So making a big kind of C loop actually helped.
Yeah. Yeah, telescoping wires I think is helpful. I've fought with this too. I'm sure everyone has. And using kind of a thin wire to just get you exactly where you want, and then an 035 microcatheter with support to sort of ultimately get a much stiffer wire is really helpful, because often delivering the device sort of just pushes, stiffens up the delivery catheter, and then it all falls out, or at least it does for me.
Even just pushing the stiff wire just pushes everything out, because the loops in the Safari are frustrating. So maybe a straight stiff or something might be a little easier. Lundy, yeah.
Right. But Paul, were you intimating that you would deliver this through a sheath?
Yeah, so
Because you didn't do that, right?
No, we didn't deliver it
he used a sheath with the torque view.
We just used the standard torque view.
But you're saying you might do this through
Go through a
steerable.
Destino or an Oscar.
Yeah.
Yeah, yeah. And still wasn't.
Because it prolapses a lot.
Yeah, yeah.
I mean, it's a 180-degree turn.
Yeah.
Yeah.
Cool.
So just highlighted why we stick to femoral access for these cases. Thank you.
Well, I guess last question. I mean, is Klinefelter's, I don't know if you looked, is it associated with, vascular, connection problems like
No,
this?
yeah, I looked into that. I did not find anything in the literature, so I think this might have more to do with the fact that he's been paraplegic for several years and wheelchair bound at this point. But no, there was no anatomic considerations with Klinefelter's. Yeah.
Great. Yeah, I was thinking that exactly, because this is, so you put a 30 in and there was still a leak. So this thing, and it's aneurysmal. So obviously the primum is coming back like an accordion, and there's a big space. So, I mean, if you could do this from the groin, I mean, it would be very reasonable to balloon size, and actually you could put an ASO, in, and this would be, I'm sure this thing would balloon stretch to at least 15 millimeters or more. But I think from the neck, you're just trying to get in and out, and the balloon is another. Was that your thought, or?
Yeah. So agreed. If this were through the groin, we would have balloon sized once we saw that on TE imaging, but it was just not possible from the neck. Everything was prolapsing, so figured a balloon would cause us more trouble.
This is less touch is more, because you can also tear these inadvertently. So, okay, we should probably move on. Thank you, Wally. So, Mark, you're up next. More plugs, more defects.
So I know you get a lot of congratulations, Paul, about this meeting, but it's stupendous. We all leave better doctors. So that's me, plugs and defects. So my first thought when you told me to do this was this case. So on the left here, there's a couple clips. This was a mitral clip case. In the middle there, you can see that there's a clip on the right side of that, in place on the mitral valve that's splayed over. That's an autopsy slide. And then there's a little defect on the leaflet where that black arrow is. So I know this wasn't the type of plug you were thinking of when you asked me to present a case here, but this is the first case that came to mind. The unintentional plugging of a right coronary artery with a mitral clip device. Yeah. Maybe, I still get nauseated when I talk about this case, but maybe next year I'll be ready. But
I think this has been reported.
it has been. Yeah.
Wow.
Yeah.
So this is your case.
No, it's my partner's case. Oh, this is all me, baby.
And is that the patient's heart?
That's the patient's heart.
Okay, so they're not alone.
It's amazing the clip was in there on autopsy. It didn't spill out when they drained the heart or anything.
I know.
Really wedged.
It's wedged in there. A lot happened before this. RP impella, RV infarct, all that stuff. A crazy case. Anyway, that's not the type of plug you're looking for. So 69-year-old gal presents, I think I did this diagnostic, I'm not sure, but it was a while ago now. Late presenter infarct. LAD is down, stented. Funny flow, something might be wrong here. Late presenter, first infarct, yada yada. So I still know how to do a ventriculogram. I do like one a year. And the hemo's there, pretty significant. Put a balloon pump in her. She wasn't sick, but a little sick. Put a balloon pump in her. And this is the challenge. She's got a, well, it's not playing, unfortunately. Can you, is it playing? AV guy. Dude. Sir. Can you get the slides to play? Can you get these to play, Chief? Appreciate it. Maybe it doesn't matter. So this is the problem. So we put the balloon pump in her, and on and off the balloon pump, you really saw that she had a good size apical infarct. Her RV was dilated, and on and off the balloon pump, when we paused it, she clearly, her shunt fraction would double. So he was unable to wean off the balloon pump, converted her to an axillary so could you walk around and stuff, and then we had a heart team discussion like we're always supposed to, and the discussion went something like this, you know, this is your problem, Ricciardi. Just buy me some time, and we'll go back in a couple months and really fix it. So this is the challenge. Ventricular-septal ruptures of this post-MI VSDs are associated with very high mortality, as we all know, whether they're treated medically or surgically. There's the guideline recommendation for emergent operative repair when there's hemodynamic compromise. We all know that that's fraught with a lot of problems. It's technically challenging. There are a lot of poor outcomes. Tissue's friable. The RV sometimes gives a lot of trouble, even if you can sew in a patch or whatever. So we do support to temporize. The fully percutaneous approach, over the years, I just get less and less excited about, but it does potentially avoid some of the risks that we see with surgery, but it has its own challenges. Pretty stiff delivery system, tangential deployment, risk of incomplete seal, pull-throughs, and then I've seen a lot of tricuspid valve injury from this too. So it's really proven to be a suboptimal thing, and that we really need a better way. So on day 11 of this gal's hospitalization, we brought her to the hybrid OR, and we did a TE-guided direct RV puncture for VSD closure through a small sternotomy. The advantage of this approach is that it requires no skill, so that's why I was able to do it, and you don't really need anything special, really at all. So what we did was, and unfortunately I did not get a photograph or a video of puncturing the RV with a Cook needle, but you can picture it. It's right there. Shortened the delivery system a little bit, and then put the wire out the aorta, just to buy a little space, and put a short sheath in there, and then the delivery system showing the middle panel there, and just snugged it up against the wall. The middle frame, maybe that'll play, but we deployed them in on the right. You can see that it's fully deployed across that. Took no time at all to do this. And then the main reason I want to show this is that we did this with the hope that maybe she'd come back in 8 weeks and the surgeon would now be the hero instead of me. But she's just done great. I mean, she had an infarct, but she really is, for the most part, completely asymptomatic. And right before getting on the plane, I asked them to do an echo for me at 5 years. And you can see there's a tiny bit of a residual leak. It's been that way since essentially day one. But she's done remarkably well with this. And the surgery was nothing to recover from. So key learnings for me here is that VSD device closure through a direct RV puncture removes all the peril of cardiopulmonary bypass in the setting of an infarct, especially when they have RV involvement. You don't have to sew into this milieu of friable tissue. It solves some of the issues with a fully percutaneous device closure, like incomplete sealing, the pull-throughs I talked about, non-coaxial deployment, and the damage to the tricuspid valves we're all real sensitized to. And it's really incredibly simple, and we've learned that it's not just a temporizing thing, but it could be very durable. All right, fire away. I do think this is, in my mind, this is the way VSD should be closed in the MI setting.
That's awesome. Now, what did you do at the RV puncture site? What did you do with that?
Well, they just put a little purse string It was so simple.
Surgeons just stitched it.
Yeah, this was through a sternotomy. So they did the sternotomy, they put the purse string, made a phone call. By the time they came back, they just tightened it up for me.
So Mark, pre-procedurally, do you do the CT planning in terms of where to puncture in terms of the RV? Just curious.
No. No. But what I did do, we used TE. Okay,
Right.
I get
That's
credit
what I
for
was
that.
thinking.
I thought
It
about
can
not
go-
even using TE.
Yeah.
But so I just pushed on the septum.
Okay.
Excuse me, on the ventricle opposite the septum. You know what I mean?
Where-
Put a little
where
indent
yeah,
on the
exactly.
RV.
So exactly
and
where.
right across from
Direct
where I wanted to
trajectory.
go. Yeah.
Okay.
Yeah, I mean, this is a great outcome. You know, these patients are often self-selected for survival or not.
Exactly.
The minute you see them, you know, because and it sounded like she was actually fairly well compensated, and the defect wasn't huge, you know, and there were rims, and she was still able to maintain cardiac output, urine output. She didn't have fulminant, you know, liver failure, rising creatinine, all the stuff that when people usually present to you with this, they're essentially dead already.
Right.
So you had some time. It was 11 days, I
Yep.
guess, after the PCI. So,
Yep.
so at that point, she's stable, and you have options. I think a lot of times we're looking at someone who's just kind of hanging on by a thread, and the very thought of just, you know, opening their chest is not even an option. So
Yeah.
we do a lot of those transcatheter.
Yeah.
You have to have the post-infarct VSD device, you know, which you can have available because it has a larger waist and larger rims. The muscular
Exactly.
VSD is not going to work very well. Occasionally we've used ASO occluders just because the disc size can be bigger.
Yep.
Ultimately, although it doesn't span the septum as well. But
Yeah.
this is a huge save. These people just, you know,
Yeah.
like that, you know, mortality is extremely
And
high.
you know, I think that you know, when we see these that are very much towards the base of the heart, all the valve apparatus, or when they're truly apical, I think we get a little frightened about doing these percutaneously. But the ones that are truly apical, I don't know if you were going to mention this, but you can probably close them too, where the more proximal disc is actually outside the heart. That's bassinet procedure that Adam Greenbaum has described.
Yeah, I mean, that was awesome, and I agree that what we're currently doing just isn't enough. I've been trying some. My current strategy, which isn't this, and maybe I'm going to evolve to this, has been to try and get CTs on all of them, and you'll often find that the entrance hole on the left side is very askew from the exit hole, right? That it makes like a river through the septum, which is why when you do them percutaneously, they often look kind of serpiginous or whatever. So I've started doing it where I get into the entrance hole on the left side, and then I electrify a wire and punch through to make a straight line to the right ventricle, and then I externalize that wire. Then you actually have to balloon the septum a little bit to get a catheter to cross a hole that you've made, and then I use cribiforms with just the pin, because I've made a smaller hole now, and all I want to do is just keep the left-sided flow from, like, I don't care about the RV exit flow, because, like, who cares? If there's no inflow, then the exit's fine. We've had a little bit of luck with it, but they still are pretty frustrating.
That's a great technique to come
Yeah.
over the fact that this is often multi-layered, serpiginous, and that's part of the issue, is that it's just Swiss cottage cheese. It's very, very difficult. I haven't done it like what you did for in VSD, but we had a case where we did it for a pulmonary valve replacement. And so it was a mechanical tricuspid, and the surgeon went to the OR, and the surgeon went through the RV, and we put in a pulmonary valve that way for a patient who needed it. So I think this is actually a really neat approach. So,
Jamie, do you find that if you do that method, you have increased stability, so you have reduced shunting just by puncturing another, you know?
I don't
I'm just
know.
thinking
I mean,
aloud.
they're just. I just wanted the device to sit more flat, right? I mean, that was the whole game, and so making a transmission. I mean, it was essentially what was done here, right? Is that you're going straight through, and so that everything kind of snugs up nicely, as opposed to kind of coming down and around. And I do think that's sort of the game, right?
Yeah. And reduce
And I
the
think in the
shunt.
early days of PFO closure, some people did not go through the PFO. They made a little hole right next to it, so they get that coaxiality. That the anatomy is more favorable. But that is a nice approach, almost as good as mine.
But
All right, we're on to our last case, and thank you, Mark. Traditionally the last case of CVI in our sessions, it's always titled "The Mother of All Structural Challenges," and I always love trying to figure out who's going to do the very last one. So, Kostas, you get the honor.
Perfect. Thank you, Paul. And what a great title, right? Starting like year one of your structural fellowship, and you're like, you get the mother of all structural challenges. But so we're struggling to find a case, and sometimes the universe helps you. So. Pretty much 2 weeks before coming to CVI, we get a phone call from an 82-year-old man transferred for NSTEMI from a neighboring state, past medical history significant for dental surgery, mechanical AVR. They did root enlargement, it's a small typo there, reimplantation of the right coronary button, vein graft to the middle AD that was done back in August of 2023. Then in September, he has another episode of NSTEMI, and at that time they PCI'd the SVG to the LAD. And they also found that he has an aortic pseudoaneurysm, which quote-unquote was at the site of the origin near or from the implant of the RCA button, and was kind of left alone. So he comes in at that point, 1 out of 10 chest pain, nitro, heparin drip, troponins were elevated, his EF is 25%, he does have severe hypokinesis of all segments with some sparing of the basal, inferior, and lateral segments, severe MR, moderate severe TR. And that was my favorite part actually of the chart. He came in with a note saying, never let anyone go back in your chest because the tissues are so friable that they're not going to be able to get out of there. So that's what we're dealing with. And I don't know how many pseudoaneurysms you've seen, but that's definitely the biggest I've seen in my short career. And there's a few things happening. So you have a large pseudoaneurysm. You have a lesion at where the SVG to the LAD is coming, and it's unclear whether that's purely compression or in reality there is atherosclerosis there. You have an RCA that has a osteoproximal disease, and you have a pseudoaneurysm that you can very nicely see that is right next to the ostium of the right. And I'll give you an orthogram before I ask everybody, what do you think? So that's what we get. What do you think?
Just quick, I mean, has this guy had routine imaging surveillance after his?
No. So it's not actually, so he's a transfer from a neighboring state. He comes in with a disc from a CT, no routine imaging. He comes in with a CT from a day before his presentation.
How long ago was his dental?
A year ago, August of 2023. So no routine imaging, just the SVG, just the PCI in January of 2024. And then he represents with NSTEMI. They do a CT, and they ship it over.
So they reimplanted the right cornea and he got an SVG to the RCA?
Yes, so, no, SVG to the LAD. So they never reimplanted left main. So that SVG is giving the whole anterior wall.
Yeah.
And I can go back, I'm sorry.
Yeah, this is not an uncommon scenario when with a Bentall or ascending aortic, graft, you get the suture line, pseudoaneurysm, either distal or proximal, and we had a fairly active vascular surgeon do a lot of this work, and there's there's a lot of ways to approach this, right? You can do a covered stent, but you've got the right coronary there. At this point, you're looking at some type of either coil or plug, and it's really like, what is the distance between the right coronary and the ostium of this pseudoaneurysm, and do you have room for a disc or something?
The inflow is not coming off the RCA. Obviously,
No,
the easiest covered stent is always just to put
yeah.
an RCA covered stent and be like, yay.
That would have been great, but no is the answer. My second question is, how do you start? Do you just go with the pseudoaneurysm, RCA, and then leave everything else alone? Do you try to tackle everything?
Fix his vein graft first.
Like do everything in the same stop and... all right, so...
Pseudoaneurysm's probably been there since day one. That's
Yeah.
not why he's presenting to you right now. The culprit is the vein graft.
Yeah. Well, we thought we should start, we agree. So we thought we should start with the SVG first, see what's happening there. is if it's truly compressing or not. And lo and behold, once we engage the vein graft, that's what you're dealing with. So it's pretty much can't get any better than this. So we wired.
The natives, you show the natives.
There is no native left main, so like they never reimplanted. So SVG is all you get to the anterior wall, and reimplanted right. So we access it. We start we're wiring. Actually, wiring was not as hard, so we were like in that context. And we started doing serial balloon dilations. We got good flow, so we decided to stent it. We post-dilated, and you can see the vein graft is back, and it pretty much gives his whole anterior wall. So that's step one. You still haven't solved everything else that's happening, and part two is what do you do with the aneurysm, with the pseudoaneurysm and the RCA? And engaging the pseudoaneurysm action was not hard. While we were trying to engage the RCA, the JR4 just jumped into the pseudoaneurysm. So we knew we were in there, so we left the catheter there. We knew we can use it. We put a second guide in, and you can see the osteal lesion, and you see how close actually the osteal RCA to the pseudoaneurysm is. So in reality, our strategy is to plug the pseudoaneurysm, use a covered stent at the ostium of the right, and then use that, have the covered stent actually deployed it after we after we close the pseudoaneurysm, so we can nicely pretty much allow for sufficient flow on the RCA. So we put
They are sharing an ostium.
it's very close. It's kind of sharing. On CT, I can show you. They're like literally one next to each other. They're not really. It's not really originating from the ostium of the right, but it's like so tightly closed that you cannot safely do one without the other. Yeah, exactly, kind of. So we pick up PK papyrus 4.0. We kind of have it in the ostium, like osteal proximal RCA, as our safety stent. So we're going to deploy it right afterwards, and we'll go with an AVP2 plug. On CT, they're measuring about 6 millimeters, so we thought that 10 millimeters will give us adequate coverage of the ostium of the pseudoaneurysm without actually having a large disc that's going to protrude in the ostium of the right more. The second problem is, how do you put your discs? Because your pseudoaneurysm is so small, like the ostium, that like we traditionally say one disc ventricular or one disc on the one side. You try to put the nice middle disc in between, and then you use our third disc as a kind of like closure on the other side. So that was our initial thought, but you can see our first attempt we tried to do that, and in reality all three discs are inside the pseudoaneurysm, so it couldn't really work. So what we decided to do is actually have two discs on the one side and then have the third disc on the outside and kind of close it that way, and you can see our positioning on our second attempt. We do use contrast to make sure that we're not really allowing anything to go into that we're truly into the aorta. And you can also see the discs, how they open up, the splitting between the two discs. So we did a few make sure it's adequate, multiple projections, and we deployed our AVP2. And you can see we have our PK papyrus ready in the place, and we proceeded with the PK papyrus placement. We tried to keep the ostium of the papyrus a little bit outside where the proximal dot of the plug is, so we can actually maintain adequate flow to the right. And that's our picture. Yeah, a type of snorkel.
So you decided to fully deploy that device before putting why'd you do that?
We actually went a lot back and forth so we just deploy the device and then crash it if needed, as much as needed with a covered stent, or should we still attach to it and deploy the stent afterwards? The reason why we decided to go that way is that once the PK papyrus is deployed, there's no way we're getting the device out, the plug. So even trying to attempt to take it out, it would totally be D-shaped under your plug, under your covered stent with the snorkeling. So we felt that whatever it is, it's going to be jailed underneath. We want to make sure we have a good coverage.
And you used the papyrus because you thought that it would feed that pseudoaneurysm?
Yes, so two reasons. One, because we felt it's going to feed the pseudoaneurysm. Two, we wanted to get as much radial force as we could. And
Yeah, because of Megatron or something
I
like that
know,
would give you
yeah.
a ton
So
of rate of
Megatron would
force,
be the
but
other.
you want it
We're worried,
covered.
yeah, we're worried that you still can get flow behind those struts, and covered stem was our.
In retrospect, I wonder if an ADO would have worked better. Jamie, do you like an ADO here instead of an AVP2?
I don't know. I have no idea. I don't. I mean, I think I actually for these, I often actually will choose an ASO. It's got a membrane in the middle. It's thin, and usually though it looks like a neck, it's just a tissue plane, right? So having a short thing, I think, works okay. But the discs, I mean, here you're just trying to balance occlusion versus occlusion of the flow into the pseudoaneurysm versus occlusion of the right coronary. So having disc-based devices may be a terrible choice. So this could be as good as any. I have no idea.
I guess my question
your
is.
decision to put 2 discs in, 1 out, as opposed to maybe having a middle disc.
Yeah. So we actually attempted it. We attempted to put because traditionally we like having the middle disc where actually your defect is. We feel you get like a better sealing and better coverage, but we tried it. We were not able to actually get a nice positioning there. So everything else was sticking out. So we felt that this way we were actually getting the best position with smallest footprint on the RCA. My question is, if you used an ASO, would you have, with a covered stent, would you have felt like there's a risk of like displacing it, since you only have 1 disc on the one side with the instant?
No, I think it
still,
usually. I mean, if you size it right, it should sit there. The ASOs work generally well for this context. It's just what's the surrounding structures and how it's going.
I mean, it was about a 6 millimeter, so the waist would be 6, and then it's plus 10 probably on, that would be, you know, so you're 16, so this is 10, the disc is 10, that might be too big. I think you guys did a great job. You know, my only thought is how much is that papyrus sticking out into the aorta? It looked like it was quite a bit, and so re-engaging that in the future will be a challenge. But
so we did. For the sake of time, I actually didn't put like all the re-engagement pictures and stuff. It does make it a little bit different for sure. That's why we tried to use a bigger one, so at least you give like more room and try to flare out the tip a little bit, so you can give more room to actually allow for further re-engagement. But it's definitely not your ideal scenario.
It's great.
That is great.
Yeah. I think we were hoping for a T-stent like approach. You were the AVPs, like the part of the T-stent. Right. But because the CT actually suggested that the origin of the PSA was off the native right, that it was not shared. But then positioning that plug, there was no way the plug was going to stay in the coronary artery. It was just too hard a position, but it turned out great.
That did turn out really nicely. I want to ask a question that I don't know, but I think about sometimes. With these huge pseudoaneurysms, after you close them, do you ever get the itch to tap it? No. Because it's gonna become a hematoma, and then it's gonna take like forever to resorb, and maybe it has external compression, and you're there, and you're like, maybe I should try and aspirate this before it becomes a hematoma. Like, wouldn't that be slick?
Everything was going pretty well until
I'm sorry, it's just like...
I mean, you're just looking to do stuff.
Are you the type that eats things that are put in front of you?
I'm just saying, like...
I mean, if it's not... I never even crossed my mind. But, I mean, it's not actually compressing anything. Yeah.
That's a massive one.
I don't know even if you aspirate it. I mean, there's like a shell of tissue. Would it actually come down, or it would just kind of create a vacuum? I don't know.
Yeah, next year.
I see the case report.
2025 CVI, tapping pseudos.
Why did you be part of the complications?
Why did you do this?
Well, thank you very much, Kostas. Fantastic presentation, and it's a great way to end the structural agenda for this year's meeting. A couple of things: we do have the challenging case competition finals next door. Lunch is there, and then next year is 2025 in Austin. We are taking votes for where 2026 will be. You can type in your favorite city through the message on the app, and I'm trying to push for Lake Tahoe, but I'm not getting a lot of traction from some other people, so that's my vote. But there's places like Miami, other places in Florida, even San Diego, other places. So if you have a favorite city you want us to consider, please suggest. And so, but it's been a great few days. Thank you all so much for being here, and have safe travels. Hope you all get home wherever you're going. So thank you.